So, I'm going to start by taking you back to 1970. It's actually before I was born, but I'm sure, looking at a few of you in the audience, you probably remember it like it was yesterday. Just to remind you, it was the year that the Beatles released their Let It Be album. It was the year that the first Boeing 747 jumbo touched down in the UK. I can see some nodding heads in the audience. It was the year that Edward Heath became Prime Minister. Someone's booed over there. And it was the year of the failed Apollo 13 mission to the moon, which has subsequently become a big movie with Tom Hanks. Even though I wasn't born, 1970 was a really significant year for me. Because 1970 was the year that my granddad died at the age of 42 of his myocardial infarction. He left my dad without a father, and my gran without a husband. And the reason why he died at the age of 42 was that back in 1970, there really wasn't any treatment that we could offer. People got aspirin, they got some morphine to ease their pain, and the concept of the coronary care unit just started to kick in. So perhaps we got a bed on the coronary care unit, but above and beyond that, there really wasn't anything to do. So when I was asked to give this talk, I thought really I would use it as an opportunity to celebrate what we do in the National Health Service and how things have improved over the last 30 or 40 years. Because we do a lot of NHS bashing, but actually it's a bloody good service that we have. You know, if you compare it with lots of countries around the world, we do a bloody good job. A lot of that is through a lot of dedicated staff. So what I'm going to talk about today is I'm going to talk about how things have progressed over the last 30 or 40 years that allows us to do better things, improve people's outcomes. Just as way of an introduction, I trained at the world's best medical school. Anybody know where this is? No. Just to give you a clue, it's also got the world's best football team, who, if there's any Manchester City supporters in here, you will be beaten tomorrow night in the Champions League. Because this is Anfield, and that's the Victoria building at Liverpool Medical School where I trained. I qualified in 2000. I then did my junior doctor years in Liverpool and Manchester. I then subsequently went to work for the British Heart Foundation, where I spent 2 years of my life researching how we can predict how people are going to survive after their myocardial infarction, see if we can predict who's not going to do well and improve their treatment. I published lots of publications around that and was awarded my medical doctorate, and then I came down to the Wessex region in 2006, where I trained as a specialist registrar in Southampton, Bournemouth, Portsmouth, as well as some subspecialty training in heart failure and complex devices. And then, as Elizabeth said, I was appointed as consultant at HHFT in 2013, where I've really been heading up what's called the complex device service. But I'm also a general cardiologist, so I do lots of what we would class as routine stuff like angiograms, etc. So what is cardiology? And I'm sure most of you here, in fact, I recognise half of you. I'm sure I've done something to many of you over the years. You probably know the answer to this. Cardiology, if you look it up in the dictionary, cardiology is the branch of medicine that deals with diseases and abnormalities of the heart, which actually is what we do the majority of the time, but we also are involved with prevention because we know that prevention is better than cure, so we're very much these days involved with risk factor modification, treatment of hypertension, modification of cholesterol, etc., etc. Just to give you a quick lesson in cardiac anatomy and physiology, I hope you can see this okay. It's quite difficult to give these talks because some people will know lots about this and some people will know little, so bear with me. The heart, as you know, sits in the chest, within the rib cage between the two lungs. It consists of predominantly muscle, which is designed to pump blood around your body. The two atrium at the top, which are receiving chambers, two ventricles at the bottom, which are pumping chambers. They have valves within it to keep the blood flowing in one direction, and the heart muscle has its own blood supply in the form of its coronary arteries. And because of the way the heart is, you can split the common cardiac conditions up into one of three categories. Either a problem with your plumbing, which is predominantly your coronary arteries, a problem with your electrics, the electrical circuit through the heart, or a problem with the engine. The heart just isn't pumping as well as it should be. So I'm just going to take you through each of those conditions, just to explain what the pathology is, and then explain how we've adapted our techniques, our treatments to try and improve people's outcomes if you unfortunately develop these cardiac conditions. So the first thing I'm going to talk about is coronary heart disease. So as I've just said, your heart is a muscle and it requires its own blood supply, which comes in the form of these things, which are your coronary arteries, which run over the surface of the heart. And they supply the heart muscle with the blood that it needs to function. And here's a coronary artery which I've sliced across, a nice healthy coronary artery which blood can flow through. But unfortunately, we all start to develop fatty deposits within our coronary walls. We all have it. It starts in our 20s, in some people it progresses more than in others. And those fatty deposits can grow and grow and grow until they encroach on the lumen of the artery to such a degree that there's restriction in blood flow down those arteries. And that is what causes angina. When your heart needs more blood, when you are working harder, it's just like an engine, it needs more petrol. And if there is not enough space for that petrol to get down the arteries, that causes symptoms, typically chest pain on exertion. And that is the start of coronary artery disease. Similar pathology, but different timescale, if you like, is what's called a myocardial infarction, what you guys would probably call a heart attack, what the media would call a heart attack. This is the same kind of thing, so the fatty deposits are developing within the walls of the artery, but what happens in a heart attack, there is a clot that forms on top of this fat, and that blocks the artery very quickly, and that's why someone will develop chest pain at rest, and typically be brought into hospital as an emergency. So it's similar pathology, but slightly different timing of events. So the typical symptoms you get with angina, chest pain, jaw pain, shoulder pain, breathlessness, which is typically on exertion or under stress. People often describe it happening in cold weather. Whereas a myocardial infarction, a heart attack, is all the same symptoms, but happens often at rest, doesn't go away if you stop exercising or if you stop walking. And I'm sure some of you recognise those symptoms if any of you have that kind of condition. The second thing I'm going to talk about is the electrics. So it's very common for people to develop electrical disturbances of their hearts. Those electrical disturbances can be due to slow heart electrics, what we call bradycardias, often due to things like heart block. Or you can develop fast heart rhythms, and probably the most common thing is something called atrial fibrillation, where the heart becomes very fast and irregular, or other related rhythms like atrial flutter or supraventricular tachycardias. But there are also dangerous fast heart rhythms, the kind of heart rhythms that can make people collapse and die prematurely. So things like ventricular tachycardia or ventricular fibrillation. So these are all things that we deal with on a day-to-day basis. Symptoms that people might develop with abnormal heart rhythms: palpitations is probably the most common. Palpitations is a general description. People often talk about missed beats, extra beats, forceful beats, racing heart. You can also have symptoms such as syncope, which is blackout, intermittent faint episode, dizzy spells, or just very non-specific symptoms, hot flushes, which could be due to abnormal heart rhythms. And then the third condition I'm going to talk about is heart failure, which is a failure of the engine. So your heart really isn't pumping as well as it should, and it's unable to pump as efficiently as normal, and that can be due to impairments of the heart muscle, weakness of the heart muscle, stiffness of the heart muscle, problems with the heart valves, all can lead to a heart failure syndrome. I'll skip over that. And unfortunately, symptoms and signs of heart failure can be quite non-specific, so breathlessness, fatigue, dizziness, swollen ankles, swollen abdomen, the inability to lie flat, what we call orthopnea, or waking up at night, waking up at night breathless, what we call paroxysmal nocturnal dyspnea. But often very non-specific symptoms. So in my experience, heart failure is a condition that's often delayed has a delayed diagnosis. And actually, we talked about cancer diagnosis. If you are diagnosed with heart failure, your prognosis, your life expectancy is actually worse than most cancers. And yet, it doesn't have the same emphasis in my view, because it doesn't have that C word, the cancer word. And I'm not saying the cancer is not important, but heart failure is as well. So I'm going to pause at this point just to make sure everyone's still on board with us. Does nobody want to ask any questions at this point before I move on to what we can do to actually treat these conditions?
Just a question, do people actually miss heartbeats or extra ones?
Do people actually miss heartbeats or have extra ones?
So the missed heartbeats is often what we call ectopics. So our heart is an amazing structure and it has built-in safety backups. So that if our heart electrics were to completely fail, which is very, very common as people get older, you will see people just keeling over in the street, left, right, centre. There's probably about 20% of people have failed electrics. Every cell within the heart has the ability to generate its own electrical signal, and if our electrics fail, those signals kick in as an emergency generator, and we see that day to day. In fact, I put a pacemaker in someone today that's electrics have failed and been kept alive by. But what the misbeats are is those emergency generators firing off test signals, and although they are still heartbeats, they're less effective. It is like an emergency generator, so people feel those missed beats or skipped beats and things like that. So it's a physiological event. Am I okay to move on? So, we've heard about 1970. What has happened since then to improve the situation, to allow us to offer better treatment to our patients? Well, there's a number of things, and I'm just going to run through one at a time. First of all, we have amazing techniques to look at people's hearts. We have ways to image the heart that we didn't before. So, for example, this is an echocardiogram. This is an ultrasound similar to the type of scan you have if you're pregnant. So we can look at the heart, see live pictures of what the heart's doing, see how well it's contracting, see how well the heart valves are functioning. And we all, the majority of us, have the ability to get these scans done instantly. Very helpful in an emergency situation, and very, can be used with portable machines, etc. We also have more complex ways of imaging people's hearts. So people may have had MRI scans of various parts of the body. We can perform MRI scans of the heart, which give us very, very clear pictures of the structure of the heart. Also give us some functional information, give us moving pictures of how the heart's functioning. So it allows us to make diagnosis earlier and more accurate. Coronary angiography is something that did exist in 1970, but probably was used in the minority of patients. So a coronary angiogram is a way to image people's coronary arteries, so the arteries that get blocked in heart attacks. And how this is done is by putting a little tube, usually into your wrist, passing little catheters up to the heart, and this is the catheter here, coming down the aorta, which is the main blood vessel of the heart, sitting in someone's coronary artery and then injecting dye down the coronary arteries. And I don't know how well it projects, but this is someone here that came in with chest pain, and you may be able to see that there's a very tight blockage in this person's coronary artery. And actually, if you come to our hospital with a blocked artery, whether it be any time of the day, 24 hours a day, 7 days a week, 365 days a year, if you come to the hospital with a blocked artery, you will have an immediate angiogram, and you will almost certainly progress onto what's called an angioplasty, which is where someone passes a wire across the blockage, which is happening here. They then pass a stent, which is a bit like a chicken wire tube mounted on a balloon, but it comes all squashed down. You blow the balloon up, which is what's happening in this picture, and then that leaves the artery nice and open. So, comparing the treatment in 1970, which was aspirin, here's some morphine, lie in your bed, see how you do. If you come into hospital now with a heart attack, you will go straight to the cath lab, have your artery opened up with a stent, and typically will go home 48 hours later. This is a lot of what I do. Pacemakers and defibrillators. Pacemakers are little battery-like devices used to treat slow heart rhythms. They sit just under the collarbone with wires down to the heart. They're very effective, they're very easy to put in. defibrillators are slightly more complicated. They're designed to treat faster, more dangerous heart rhythms, so they can identify those heart rhythms if someone were to suffer them, and can intervene either by pacing the heart in a very specialised way or by giving a shock to the heart. So it's a bit like the kind of thing you see on casualty where this, like it says, stand clear, but they do it automatically from inside, and they can be life-saving in many situations. This is a picture of putting a pacemaker in, but essentially it's all done through the little incision at the top. We do everything under X-ray guidance, so you can see the pacing wire in the heart there. This is a slightly more specialised pacemaker known as a CLT pacemaker. So I put this in because I think it gives a nice pretty picture of your coronary veins. So these are the veins within the heart. I've got a catheter within those and a balloon blown up, which allows me to take nice little pictures. And then once I know where the veins are, I can pass wires out to allow us to pace the heart in very specialised ways. So this is something that wasn't offered at HHFT until I came in 2013. We've now been doing it for 5 years. We have a very successful program, and as of last year I have a colleague, so that it means I don't have to do them all, because I was doing somewhere between 300 and 400 pacemaker devices a year. It's slightly less now, but numbers are increasing as well, so I'm still busy. Ablation therapy is something we don't do at the moment, but we certainly have a vision to try and introduce it. Ablation is a technique to treat short circuits within the heart. This is a very complicated picture which shows all sorts of catheters within the heart, but essentially what these techniques can do is identify short circuits causing abnormal electrical activity, and by taking catheters into the heart they can be ablated either by giving heat or freezing energy. So at the moment, one of my colleagues, Rob Bowers, takes all our patients down to Southampton that need this procedure, but we certainly have hopes that we'll be able to offer this service within the next few years. So we do all these fancy things, they're pretty cool, but has it actually made a difference? Well, thankfully it has. So this is the mortality rate due to myocardial infarction over the last 40 years. So on the left is where we started in 1970 with James Kelly dropping dead at the age of 42, which I've just realised is the age I am in 2 weeks' time, which is a bit terrifying. But you can see the mortality rate has dropped significantly. This is 2005 here. This is the most recent data I could find on a nice graph, but actually the trend is continuing downwards, so we've probably reduced the mortality rate. This is nationally by about 2/3. So I think we are doing things right, we are getting things better. This is not all just about us, this is also about better identification of symptoms. Patients are much more aware that they should come to hospital with chest pains, smoking cessation, diets, all those things. So lastly, but probably most importantly, what can you do to reduce your risk of developing cardiovascular disease? Well, the first thing is to be proactive and not reactive. And I think if you want to take anything positive home tonight, the fact that you are here listening to talk about healthcare demonstrates that you are involved with your own healthcare and you are being proactive. And we know that patients that are proactive with their healthcare overall do better. It's about empowering you guys to be engaged with your healthcare. So I would suggest that you have a think about what you do to improve things and what potentially you could do to improve things. Speak to your GP, speak to your pharmacist, speak to your cardiologist, improve your general well-being. Cardiac rehab here, you have an amazing facility here in Alton with the Cardiac Rehab Centre. They're not only just there for patients who've suffered with cardiac disease, but they have a lot of classes, programs designed to reduce your risk. So go and talk to those people at the end of the session as well. And risk factor modification. So when we talk about risk factors, we talk about things that increase your risk of developing cardiovascular disease and what you can do to adjust that risk. So unfortunately, the things you can't change, so you can't change your sex, you can't change your age, unfortunately, and you can't change your parents, so you can't even change those genetics you inherit. So I know I'm going to get cardiac disease because it's in my family, but I can change a number of things, what we call modifiable risk factors. So if you've got hypertension, you should address that. Diabetes, smoking cessation is exceptionally important. If you have a heart attack and you carry on smoking, you are going to come back with another one. Obesity is a major risk factor for cardiovascular disease, as is your cholesterol levels, and all those tie in with lack of exercise. So if you exercise, if you engage in an exercise program, you're going to lower your weight, you're going to stop your diabetes, you're going to lower your blood pressure, you're probably going to have effects on cholesterol as well. So stop smoking, eat a healthy diet. It's all about Mediterranean diet, lots of oily fish. You don't need to add salt to your food, there's enough salt in food these days. Moderate amounts of alcohol, and exercise. So where are things in the future? Well, as you've just heard, this was our hope and our dream, the critical treatment hospital which was going to be built between the two sites, which would have been an amazing facility with acute services, cardiac, pediatrics, obstetrics, ITU, but certainly for the time being this has been put on hold. So we'll see what happens. But certainly from cardiology overall, there's a lot of exciting things going on. So these are just a few examples. So pacemakers are continually being miniaturized. So this is an injectable pacemaker. One of the biggest failure points with a pacemaker is the wire. Imagine if you got an electrical wire and did this with it 60 times a minute for 10 years, it would cause a problem, and that's what those wires are doing inside your heart. So in order to minimize those risks, we're taking away the wires. Certainly for patients with end-stage heart failure, things like total mechanical hearts could become a feature. We know that patients who require transplant, there's not enough organs, and therefore using some kind of mechanical device. This thing here is called a left ventricular assist device. It's a device, again, for patients with very severe heart failure, which takes blood out of the main ventricle and pumps it under high pressure back into the body. So I've got 2 patients living with LVADs at the moment. The biggest problem is they have to be charged up every 12 hours or so, and that requires a charging pump to come through the skin. But what's called transdermal pacing is very much going to happen in the next few years. So the way that your electric toothbrush charges itself by not having to plug it in, you just put it on something and that will happen across the skin. There's hope for stem cells. You've probably heard stem cells on the radio. Stem cells are kind of the building blocks. So the idea is you trick stem cells into turning into heart cells and regenerating damage done to the heart. And then there are other things as well. So I think there is a lot of exciting things going on in cardiology. Our results have been good, but as always could be better. Let's see what the future holds. There's lots of support out there. British Heart Foundation, NHS Choices, lots of charities such as Cardiomyopathy, Pumping Marvellous, Arrhythmia Alliance. So if you want any signposts to the right places to look for information, then please do let me know. So finally, I'm going to end with a blatant plug, I'm afraid. However, it's subtle. However good your cardiologist is, however healthy you are, I'm afraid you are all going to meet your maker at some point. And the services that our palliative care offer at HHFT are outstanding. And what is lacking at the moment is a big hole in the centre of the patch where hospice services aren't available. So even if you're not local to Winchester, you may have family, friends who may need this kind of facility in the next few years. So we're currently trying to raise £2.5 million to regenerate this lovely building on Winchester Hospital site, which used to be one of the nurses' accommodations. Not only has it been an eyesore on Winchester, it also is a perfect facility to turn into Winchester Hospice. So £2.5 million is required. I think we're currently about 800,000, if that's right. So there's various ways to donate. If you wish to, you can go to the Just Giving website, or if you want to text to donate. So that is my blatant